I am an assistant professor in the Division of Medical Oncology at the University of Colorado. Lung cancer has undergone some amazing transformations in the ways that we can help take care of patients. And really the two trials I'd like to emphasize are very similar themes as to what's been going on previously, and that is biomarkers are king. So when patients are diagnosed with metastatic lung cancer, biomarkers are really important for helping people like me decide what therapies are best to treat my patient with. And the first that I want to emphasize is one that reminds us all of how important PD-L1 is. PD-L1 is a marker on cancer cells, and we use certain levels as cutoffs to decide whether or not patients can receive immunotherapy alone or whether they might receive immunotherapy plus chemotherapy. And recently, there was a 5-year update to KEYNOTE-024, and this was a very large trial in the lung cancer world that randomized patients to either receive pembrolizumab alone or to receive standard of care chemotherapy at that time. And recently, they reported the updated 5-year overall survivals for these patients, and it was remarkable. So for patients who receive pembrolizumab alone, almost a third of patients are still alive at 5 years. Additionally, if patients happen to recur, if they happen to have a recurrence of their lung cancer, retreating with pembrolizumab at that time is also an effective way to get the cancer under control again. And so I think this first trial is one that really firmly establishes the role of the PD-L1 biomarker for patients with lung cancer, as well as the choice of using pembrolizumab as a first-line option in patients with a high PD-L1 status. Yes, absolutely. It is set at 50%. So if greater than 50% of cancer cells express PD-L1, it's considered to be PD-L1 high. And the cut point is one where you can have a discussion with patients about whether we use immunotherapy alone or whether we use immunotherapy plus chemotherapy. There are certain clinical circumstances where one might want to use monotherapy, so pembrolizumab alone, or pembrolizumab plus chemotherapy. So at 5 years' time, nearly a third of patients were still alive. I think the exact number is about 31 or 32%. The other trial that has really come to the forefront in discussions in academic oncology practices in the United States is the Adora Trial. And the Adora Trial randomized patients who had completely resected lung cancer that were EGFR positive to receive standard of care or standard of care plus osimertinib. And so this trial has generated a lot of discussion, and I think going with our biomarker theme, this is one of the trials where these biomarkers that we often use in metastatic disease may also become important in patients with early stage disease where we treat them with curative intent. So with Adora, patients had lung cancer that was resected. That's standard of care. And then if they had the EGFR mutation, which in the metastatic setting is often sensitive to tyrosine kinase inhibitors or oral therapies that prevent certain mutations from being active and causing cancer cells to grow, they could either receive standard of care chemotherapy and observation, depending on their stage, or they would receive that same standard of care, but then afterwards receive 3 years of osimertinib. And the reason that this trial has generated so much discussion and so many different opinions on what to do is that it was an early report on the data. And so we don't have clear survival data, meaning adding in osimertinib would help patients live longer. What we have is a measure called disease-free survival, meaning in the patients who received the osimertinib for 3 years, those patients had reduced chances of recurrence of their lung cancer compared to the control group. The challenges are, in terms of interpreting this and how we take care of our patients, are twofold. One is previous trials have been done very similar to this with older generation EGFR inhibitors, and eventually the survival curves meet. And what that means is we don't help cure more patients by adding in those older generation TKIs. But on the same hand, some argue that the degree of disease-free survival is so significant that patients need to be presented with the data and have an opportunity with their physician to make an educated choice about whether or not they would like to do the osimertinib therapy. And so with this trial, in my mind, the way it's changed my clinical practice is that I have this type of discussion with patients with completely resected lung cancer who are EGFR positive, and we really talk about the pros and the cons, because right now we simply don't know whether or not this helps cure more patients with resectable lung cancer. Yes, and I wish that was the case. What we know about lung cancer is that it has a propensity to recur, even with excellent surgeries, not only taking out the tumors, but also taking out the lymph nodes in the middle of the chest. Unfortunately, lung cancer has a high likelihood of recurring. And so one of the main things that we talk about with patients is the use of adjuvant chemotherapy. That's been part of standard of care for lung cancers that are a little bit larger or involve lymph nodes in the chest. And that chemotherapy has been shown to provide a survival benefit after surgery, meaning that chemotherapy helps to kill the very small residual cells that just happen to be remaining even post-surgery. And the Adora trial is trying to add on to that, because even with surgery and chemotherapy, even with no evidence of disease, unfortunately, a large number of patients still have recurrence of their lung cancer. And the Adora trial is trying to improve those numbers even more by adding in specific therapies that target mutations certain patients can have. Yeah, no, that's a great way to put it. And what we see when we use this in the metastatic setting, so right now in the United States, osimertinib is the first-line choice for patients newly diagnosed with metastatic EGFR positive adenocarcinoma, a type of non-small cell lung cancer. And while the vast majority of patients have a response to therapy, meaning the disease shrinks and is under control for some time, often years, eventually it does recur. So those cancer cells are able to find out ways to get around the suppression, the inhibition by osimertinib. There's a number of different mechanisms that are known, and sometimes there are mechanisms that we just can't identify, how the cancer cell was able to figure out how to avoid the effects of osimertinib. So it's possible that in the curative intent setting, where patients undergo the surgery, undergo chemotherapy if appropriate, and then do the osimertinib for 3 years, that if they do recur, one of the concerns is that their lung cancer might no longer be responsive to osimertinib because the cancer was able to determine a way around that therapy. Very much so. A lot of the oncogene-driven lung cancers, and EGFR mutations are one of them, have a propensity, or they often are found with brain metastases. So with the Adora trial, when patients did recur, there were fewer CNS, recurrences with the osimertinib, and that would also be a result that's expected, because what we know about osimertinib is that it's able to get into the tissue of the brain. It's able to penetrate something called the blood-brain barrier, so that it can exert its anti-cancer effects in that area as well. I have a number of patients I take care of who are probably in that category of patients who received pembrolizumab alone, who are probably not going to recur. So they have no evidence of disease, and they've been on it for several years. It's really incredible to see. That is not how it was. I'm really excited for a number of trials that are going to start to read out, and we'll get some reports on them at the World Conference of Lung Cancer later this month. The first is on CodeBreak 100, and that's with using the KRAS inhibitor sotorasib. And so KRAS has been a known oncogenic driver in lung cancer for 40 plus years, and for about the same amount of time, people have been trying to design drugs that inhibit the KRAS mutation that's found in about 12 to 13% of patients, especially those with adenocarcinoma. And so a number of KRAS inhibitors have come into trials and are being used in clinical trials right now. And it's very exciting because it appears we're starting to get signals of efficacy from these drugs, even in the phase 1 reports. And so what's coming up at the World Conference of Lung Cancer is the phase 2 data with sotorasib is going to be coming out, which will give us a better idea of response rate, how long patients respond on this inhibitor, as well as some of the side effects or adverse events that are being seen with this drug. The other trial that I'm really excited about is the report from LCMC3. And so LCMC3 is a large lung cancer consortium where they gave atezolizumab, so that's a PD-L1 inhibitor, to patients before they had their lung cancer resected. So the hypothesis was giving immunotherapy before surgically resecting lung tumors will help patients do better. The hope is that the immune system can be activated to start eliminating some of those cancer cells. And I'm really excited about this trial because I think neoadjuvant or before surgery immunotherapy, whether alone or in combination with chemotherapy, is really going to be the next breakthrough for our patients with lung cancer. And I'm hopeful that this will result in more cures of patients up front so that we have fewer patients who recur with metastatic disease. And so LCMC3 is going to report out their primary analysis of outcomes as well as outcomes as well as safety. Yes, and it's exciting to see all of these therapies that were new to all of us not that long ago really make these leaps further into curative intent therapy. Yes. Right now in the United States, we use durvalumab. So if patients have unresectable stage 3 lung cancer, they get concurrent chemotherapy and radiation therapy. And then we give them a PD-L1 inhibitor, durvalumab, for a year. And that has also significantly increased cure rates for that population of patients. So hopefully moving it to even earlier stages, so where patients are able to have their cancer resected, this will result in even better outcomes. With the coronavirus pandemic, a number of changes have occurred in the way that we take care of our patients in medical oncology. And I think one of the things that we have learned, and I hope we will continue to take forward even when the pandemic is under control and hopefully that will happen soon, is that doing virtual visits is a effective way of helping to care for our cancer patients, especially those that are long-term, either doing well on, for example, TKI therapy and have done well for years, or if we're doing a surveillance visit where we're updating scans and making sure things are okay. Talking to patients through virtual visits is really a nice way to provide care. It eliminates, of course, having to drive in, park, manage their way through our academic institution. And it also it allows for doctors to see patients in other areas of the country. So sometimes there is a significant travel component that some patients have to do. And it's nice because we can just, visit them in their home. So I think that's one of the major points of change I think will carry forward even after the pandemic. Our understanding really crystallized as we sort of got more information about the virus, as well as tried to continue practicing, and that is cancer doesn't wait. When people are eligible for curative intent therapy, we should do everything we can to provide curative intent therapy, as per the normal standards outside of the pandemic. There was a really interesting article in, I think, the British Medical Journal. But what it did is they took a number of registries and data points to better understand what the cost was in terms of outcomes for delay in cancer therapy. And so they were able to look across a number of different cancers, and really what they saw is that even a 4-week delay, or even more than that, could reduce the chances of patients being cured. And I think that has played out in our clinical practice anecdotally. Patients, unfortunately, are coming to us with more advanced disease. We're seeing the early stage cancer patients less. And I think that was in part because of what we were offering to do, trying to just keep it to the bare essentials, as well as patients being afraid to come into a large medical center where there are, people who are not well. The other ways that we've worked around the pandemic, of course, are structural things, meaning, fewer visitors are allowed coming into the appointments with the patients, or when they're, in their infusion, we limited it to one additional person. And then, with our patients and the changing landscape in terms of distribution of the COVID vaccine, we're also, actively keeping them updated with what our specific institution is doing, as well as the conversations that are going on as to when they could potentially expect a COVID vaccine.